Okay. Yeah. Hello, everyone. So today we'll be continuing the discussion on short stature. So yesterday we had finished on familial short stature and constitutional delay and on the endocrine causes. Uh, okay. Yeah. So welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant in Bangalore, and I have an experience of teaching undergraduate and postgraduate medical students. I have done my MBBS and MD from Rajiv Gandhi University of Health Science. Okay, so today we'll be discussing the remaining part of short stature that includes genetic causes and skeletal dysplasias. So before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform, and you get access. Yeah, so you get access to daily live classes. Okay, so you can educate with your. I mean, you can engage with your educator. You can ask your doubts, and that gets clear then and there. Also, the Unacademy provides you with structured courses. So for any preparation, you have to structure your course so that so that you will be able to plan your preparation well for this entire 1 year. So that is why structured approach to your preparation is very important, as well as to evaluate yourself to know what is your strong area and your weak area. Live tests and quizzes are very important, and Unacademy provides you with it. So there is a regular mock tests and quizzes happening in this platform, and that will help to analyze yourself better. Okay, and so this will be a big help, and you'll be able to concentrate better on subjects you feel you're not good at. Next, coming to the unlimited access. So if you subscribe to the subscription, you get access to unlimited access to all the recorded classes, live sessions, revision classes, and all this with the in the comfort of your home using your own device. Okay, so I would highly recommend this platform, and using this opportunity in the beginning part of your preparation would help you and take you a long way. Okay, so these are our top educators. So they all I mean give lectures every day, so attend their class as well. So all the subjects are the courses for all the subjects are provided in this platform, and these are the ongoing courses in our platform right now. Now coming to the NEET subscription package. So as you can see, we have our subscription package ranging from 1 month to 2 year. So I would recommend this 1 year or the 2 year package. So, and if you use my code Shilpa 10, you get a 10% discount. So actual price of a 1 year course is 25,000, but you get for with a 10% discount for 22,500. Okay, and for a 2 year course, the it costs 30,000, and if you use my code Shilpa 10, you get a 10% discount, and it comes up to 27,000. So I would highly recommend this. So you're getting very good discounts, and make the best use of it. Okay, so today's before going to the rest of short stature, I would want to summarize or revise yesterday's. Okay, yesterday's topic. So basically, what did I say? Uh, so what are the factors which affect? The factors which could be is familial or genetic, ethnic factors, um, well-being of the child, hormonal regulation of growth. Familial, you understand, it is highly height is a uh, highly heritable parameter, while ethnic factors, I've told you, it all depends on change in the place. As I've told you, the northern European people are considered to be the tallest. Hmm? So ethnic factors matter. So well-being of the child. So a child who is well and happy, they will surely achieve their what is it, potential. While children who have chronic illness tend to lose weight, and that will lose weight, and that will eventually show decrease in their height. Okay. Hormonal regulation. So there are hormones which promote growth. That is growth hormone, thyroxine, steroids, is estrogen and testosterone. And the hormones which decrease the, I mean, inhibit the growth is glucocorticoid. Okay. Also, emotional factors also play a very big role in growth. So children who have emotional disturbances can have psychosocial dwarfism. So and what was height? I discussed as height as any height less than 2 standard deviation below the mean age is called as short stature. What is growth failure? If the growth velocity, this is very important, the growth velocity is below 25 percentile. Okay, 25 percentile, then it is referred as growth failure. What is a dwarf? If the height is less than 3 standard deviation, I mean, sorry, um, this is more, okay, sorry, more than 3 standard deviation below the mean for age, called as a dwarf. So these you need to know. And as I said, how do you approach? So first of all, when a child comes to you with short stature, you need to get the height checked, then get the mid-parental height and start it on the growth chart, so that you see if the child is in the line of growth as their parents, or it's way below. Okay. And then check the upper to lower segment ratio to see if it's a disproportionate short stature or a proportionate short stature. That will help you to rule out many conditions. Okay. And weight. Okay. So generally undernutrition is generally undernutrition, as I mean, loss of weight is very rarely could cause a short stature, but it could be because secondary to conditions like malabsorption, poor nutrition, and systemic illness. But if the child comes with increased weight, obese child comes with short stature, then you have to always think about endocrine causes. Okay. Endocrine causes and genetic causes like Prader-Willi syndrome, Lawrence-Moon-Beadle syndrome. Okay. Yeah, so these are the things you need to always check when a child comes. So now approach. So you have checked everything. So now you need to know the normal and pathological variants. So normal variants are the familial and constitutional delay. While pathological, I've told you there are skeletal dysplasias. So that is achondroplasia, hypochondroplasia. Okay, so osteogenesis imperfecta. There are so many skeletal conditions. Okay, there is rickets also. So rickets I won't be discussing in this discussion. I'll be discussing it when we go to nutrition chapter. Okay, so skeletal dysplasias. Next, there could be an IUGR child, okay, who does not may not catch up and end up being short. Okay. IUGR can cause endocrine causes. So endocrine, as I've told you, growth hormone deficiency, hypothyroidism, Cushing syndrome. So diabetes mellitus, diabetes insipidus if not treated. Okay. So these can cause short stature. Also chromosomal abnormalities like Turner's, Noonan syndrome, Prader-Willi syndrome, Down syndrome, Okay, so and Seckler syndrome. So these are the syndromes which can cause, which are chromosomal causes. I mean, chromosomal abnormalities leading to short stature. Okay. Also, when there is insulin growth factor deficiency, which can cause growth hormone insensitivity. Okay, so example for this is Laren syndrome. So I have discussed all this. So today we'll be discussing about skeletal dysplasias and chromosomal abnormalities. Okay, let us go. So genetic causes. So firstly, today we'll discuss about Turner syndrome. Okay, so Turner syndrome has an incidence of 1 in 2500 live female births. Okay, so basically, what is the chromosome defect here? Okay, so the chromosome is there is absence of X chromosome, and as a result, the karyotype is X45 X4. Okay, so and so as a result, so these children are normal size at birth. Okay, but their features, the first most important feature is short stature. These children present to you with only short stature. There might not be any dysmorphic feature also. So why there are multiple reasons why Turner, Turner syndrome children end up having short stature. It's multifactorial. But the a recent study has shown as HOX, that is short stature, the gene. Okay, short stature, homeobox. Okay, gene to be responsible. So this gene is required for normal development. Okay, so they are highly concentrated in the skeletal tissue, and they are present in the X and Y chromosome. So now what happens in Turner syndrome? There is absence of one X chromosome. As a result, only half of the gene is here, and that is why that leads to short stature. So this is a research recent study which has shown short stature in Turner syndrome is due to the mutation in or due to the absence of SHOX gene. Okay, short stature homeobox gene. Okay, so what are the features? What are the other features you need to know? Okay, so a child with Turner syndrome comes with webbed neck. So I'll try to depict I don't know if you can, sorry, over here. So, so a child, if this is a normal child, I don't know if you'll okay, so this there can be webbed neck. Okay, so there is webbed neck. Then there is low posterior hairline. Low posterior hairline. Lymphedema. Lymphedema. There is thickening of the skin. This is especially in the hands and feet. So all this is seen at the time of birth. Okay. There is increased carrying angle of the arm. These all you will be knowing, but it should be a revision. You shouldn't forget them. So pigmented nevi, short fourth metacarpal. So these are the things you need to know. Okay, and what is a cardiac defect which happens in a child with Turner syndrome? The most common cardiac defect is coarctation of aorta. This is a very important question. You need to know that. So I feel in this, especially in this topic, Need to know, one second. Yeah, this should be an important question. Okay, and maybe the incidence. Okay, and you should know the cardiac defect, the most common cardiac defect which happens in a child with Turner syndrome. So these need to be known. Okay, yeah. Next, coming to Prader-Willi syndrome. So Prader-Willi syndrome children uh, present with hypotonia, there is failure to thrive, there is hypogonadism, especially cryptorchidism in males. Okay, there is these children have short stature with small hands and feet. Okay, and these children, another thing what you need to know is these children have hyperphagia. As a result, they have morbid obesity. So that is why what I said in the previous slide, a child who comes with obesity and short stature, you need to know, you need to rule out endocrine causes like Cushing syndrome, hypothyroidism, growth hormone deficiency. Also, you need to rule out genetic conditions like Prader-Willi syndrome, Lawrence Moon Beetle syndrome. Okay, so these children have they have increased appetite, and they might end up being morbidly obese. Okay, they'll have developmental delay, intellectual impairment will be there. Okay, so average height comes up to of an adult can be uh, maximum 140 to 145 centimeters. Okay, so what is the genetics? So important. So genetics. Um, so in so, so here what happens is there is absence or inactivity of a segment of paternally inherited chromosome 15. So what is this? Okay, so in chromosome 15, okay, just imagine this is a chromosome. So in the chromosome there is a part, okay, segment which might be absent, okay, in the child. So that might lead to Prader-Willi syndrome. Prader-Willi syndrome. Okay, so it can either absent or it might be inactive. So the similar thing, if it is a maternally inherited uh, chromosome, it is called as Angelman Engelman syndrome. Okay, sometimes in this Prader-Willi syndrome, what can happen is, so this has to be a paternally inherited chromosome. So if it's chromosome 15, there are two chromosomes which are. So if both the chromosomes come from the mother, then there won't be a paternally inherited chromosome. So this is another uniparental disomy. So Prader-Willi can either happen because of the absence or deletion or the inactivation of the segment of the chromosome. That happens in 65% of the cases. Rest 30 to 35% of the cases can have maternal uniparental disomy, and that could be another way of inheritance in Prader-Willi syndrome. So there are two types. Okay, so investigation, they do a DNA methylation probe. So here what we need to do is they check for maternal pattern of methylation and paternal pattern of methylation. If the paternal pattern of methylation is present, then it is normal. Okay, but a maternal pattern of methylation will be abnormal. So once an abnormality is picked up, then you need to get a genetic test. Okay, a genetic test to rule out, I mean, what kind of inheritance it is. That is it because of deletion, it's because of disomy, or is it because of imprinting? So I think you understood how a deletion can cause Prader-Willi syndrome and how a disomy can cause Prader-Willi syndrome in this case. So I hope you've understood. Okay. So treatment, growth hormone helps for the height. Okay. So now Russell Silver syndrome. So Russell Silver syndrome here, this is very important. So in a child who is an IUGR, you have to always, severe IUGR, you have to always keep in mind Russell Silver syndrome. Okay, this is the child with Russell Silver syndrome is characterized by severe IUGR that persists postnatally. Okay, so these children have proportionate short stature. Proportionate short stature. Okay, they also have normal head circumference. They have a triangular face. Okay, they have a triangular face. Then they have a prominent forehead. Remember, they have a fifth finger phenodactyly. See, all this is important. You need to remember, because for syndromes they might suddenly give one feature and they might ask you which of the following syndrome has this feature. So you need to remember some of the main things you remember. Okay. Hmm. So and there can be hypo hemihypertrophy. So one or one side of the body might not be developed well. So there might be hypertrophy. Okay. Mild developmental delay can be there. Yeah. So now what is the genetics here? They're associated with methylation abnormality. Same thing like Prader, but it's a different. So, but the inheritance is by imprinting on chromosome 11. Okay, so 60% happens because of imprinting. This is 60% of the children with Russell syndrome is because of Russell Silver syndrome is because of imprinting, and 10% is because of maternal uniparental disomy. Disomy. Okay. Um, and the rest, so 60 plus 10, 70. So the next 30%, the mechanism is still not known. Okay. And treatment, growth hormone helps, but in high doses, is required in high doses, as there could be chance of um, growth hormone resistance. Okay, so now coming to the short stature homeobox mutation. So this is important, something new. So so these, I said these are no, sharks, whatever, sharks gene. This is a should be normally present. Okay, because it helps in growth. Okay? So this is called as a pseudo autosomal gene, because it carries an autosomal character, not a uh, sexual character. I mean, okay, and it is present in the X and Y chromosome. So, what are the features? So, if there is an abnormality in this gene, what are the features? And another thing is, this gene is highly concentrated in skeletal tissues. So, what are the features you need to see? So, first thing, a Madelung deformity. So, as you all know, Madelung deformity is a dinner fork, dinner fork deformity of the distal forearm and wrist. So, the dinner fork deformity. Okay. There is mesomelia. So, what is mesomelia? Mesomelia is the shortening of the distal limbs. So, there is shortening of the forearm and the legs. In there is cubitus valgus. Dislocation of ulna. So most of these features are from on the forearm. I mean the distal arm. So it's in Madelung deformity again is the dinner fork deformity of the forearm and the wrist. There is mesomelia. There is cubitus valgus. There is dislocation. So all these come in the distal part of the upper limb. Okay. So if a child presents with short stature and the above features, it is called as Lori-Weill dyschondrosteosis. So basically, short stature, I mean, this short gene mutation can be there in so many conditions, as I've told you, even in Turner syndrome. But if a child with short stature comes with these features, then you have to think about Lori-Weill dyschondrosteosis. Okay, so how do you screen these children? Okay, so these children should have short stature with the above features. Also, they should be increased upper body to lower body ratio, decreased arm span to height ratio. So without these features, the conditions, without these features, the screening test becoming positive is very rare. So always a child with short stature with the above features only gets uh, I mean, it's taken for screening. Okay. Treatment again, growth hormone. Noonan syndrome. One second. So coming to Noonan syndrome, what is the incidence of Noonan syndrome? The incidence is 1 in 1000 to 1500 live births. Okay, the most common gene. Okay, the most common gene involved is PTPN11 gene. But this syndrome is very heterogeneous. Okay, it has around 12 genes. Okay, there might be there could be 12 genes which are associated with Noonan syndrome, but the most common is PTPN11 gene. Okay, so how does these children present? There is facial dysmorphism. So what is the facial dysmorphism here? There is hypertelorism, downward slant eyes, low set ears. Okay, so these are the yeah. So these are the facial dysmorphism you see. What are the cardiac lesions you see here? So cardiac lesions, eh, this is a more of a right-sided heart disease. Okay, so that could be pulmonic stenosis, hypertrophic cardiomyopathy. Okay, so remember, facial dysmorphism with hypertelorism. There is hypertelorism, there is downward slant of the eyes, and there is low set ear. So these are most commonly seen in most of the children with developmental delay. And what is a cardiac lesion you see? There is right-sided heart disease with pulmonic stenosis, hypertrophic cardiomyopathy. Okay, now other features are webbed neck, pectus excavatum, cryptorchidism, there is bleeding diathesis, lymphedema, and there is intellectual delay. Okay, so as you can see, there are so many features uh, similar to Turner syndrome. So this is called as pseudo Turner syndrome. Pseudo Turner syndrome. But both males and females are affected in Noonan syndrome. Okay, so a condition which is called pseudo Turner syndrome is Noonan syndrome. Keep that in mind. Okay, so growth hormone as treatment, growth hormone is FDA approved. Growth hormone is used for the short stature. So next is sickle cell syndrome. So sickle cell is also called as bird beak dwarfism. So there is dwarfism in the name of the syndrome only. So it's called bird beak dwarfism. So this is an autosomal recessive. There is autosomal recessive type of inheritance. There are 7 types of sickle syndrome based on the gene mutation. So remember the sickle types. So that's called sickle 1, sickle 2, sickle 3. There are 7 types. So there are a lot of 7 types of genes to remember, but I don't think that is it will only confuse you. So I'm not going to involve it here. So what are the features of a child with sickle syndrome? So keep all this in. I made it very short. Just keep this in mind. So there is marked growth failure. Okay, there is microcephaly. There is a hypoplastic face with a prominent nose. So a child who has a short stature, the dysmorphic face. Remember, child who has a prominent nose, you have to think about sickle syndrome. Okay, low set ears, low set or malformed ears. Okay, yeah. So you need to know. So sickle syndrome is also known as bird beak dwarfism, and they're autosomal recessive, and they have a broad genetic heterogeneity. They have marked growth failure, there is microcephaly, the face is hypoplastic, but they have a prominent nose, and they have a low set or a malformed ear. Okay, now coming to skeletal dysplasias. Okay, now skeletal dysplasias are due to the failure of the bone or cartilage to grow normally. Okay, so because of this they might have short stature, disproportionate short stature. Okay, so very important feature of skeletal dysplasias is they have a abnormal body proportion, and bone age is not reliable. So bone age is very important when we evaluate a child with short stature. Here in skeletal dysplasias, bone age is not reliable indicator of osseous maturity. Okay. Huh. Now coming to achondroplasia. So achondroplasia has an incidence of 1 in 20,000. Okay. So these are generally they have a autosomal dominant kind of inheritance, but sometimes there can be de novo mutations. Okay. So what are the features? So at birth, they're present with short limbs, long narrow trunk, large head. There is midfacial hypoplasia. So they might have a saddle nose with the large forehead. Okay, so midfacial hypoplasia, hypotonia. Okay, so at birth you can see that the child already, I mean, it is possible to diagnose at birth. So they are present with very short limbs, they have a long narrow trunk, they have a large head, and they have a midfacial hypoplasia, they have a dysmorphic face, and also present with hypotonia. Okay, as infancy happens, the growth failure is further worsened. Okay, and the infant can have shortened humerus and femur. So now what do you call this? The humerus and the femur is shortened. So there is proximal shortening. So proximal shortening is called, okay, proximal shortening is called rhizomelia. Okay. Uh, so further what can happen in their hands? The hands, they have a trident hand. There is a three-pronged configuration. So just remember trident hand. Okay. So in these children, hydrocephalus can happen. How does hydrocephalus happen? That is because of the narrowing of foramen magnum. Okay, foramen magnum. There can be stenosis of the spinal canal. Also, there could be kyphosis can happen. Okay, so this is very important. Okay, so if a question comes, what are the complications of achondroplasia? So hydrocephalus, the stenosis of spinal cord, kyphosis, all this can be taken into account. So what on X-ray? What do you see? You see small. You see small cuboid vertebra, and there is anterior beaking of first and second lumbar vertebra. Remember that. Okay, lumbar vertebra, and as you know, his lower limb is also short. So what is the treatment? As such, there is no approved treatments, but there are trials happening with the C-type natriuretic peptide. Okay. So, it is said that there is it stimulates bone growth, but it has been done only in animal models, and the treatment for it to come is still pending. So next, coming to hypochondroplasia, this is the allelic variant. This is the allelic variant of achondroplasia. Okay? So these children might not present at the time of birth, and their short stature and disproportionate body was uh, might be noticed at around 3 years of age. But learning disabilities are common here. Okay, so they reach an adult height of 116 to 146 centimeters. Okay, next, the radiology is not much different from achondroplasia. The treatment over here, use recombinant growth hormone. Okay, so the gene which is affected here is FGFR3. So even in achondroplasia, the gene which is affected is FGFR3, but the codon differs. So in achondroplasia, the codon is 360, codon 360, while for hypochondria it is hypochondroplasia is codon is 540. So try to remember, let's see. So osteogenesis imperfecta is also a form of skeletal dysplasia, but here the children might not present you with short stature, as they have severe other problems like multiple fractures. Okay, but the short stature of osteogenesis imperfecta is proportionate and not disproportionate. So most of the skeletal dysplasias present with disproportionate short stature, right? So in osteogenesis imperfecta is proportionate short stature. Okay, so now, so as you have seen, growth hormone has a lot of, I mean, has been used in all these conditions. Most of the conditions, treatment is growth hormone, right? So but growth hormone has quite a lot of side effects as well. So first thing is fluid retention. There could be increase in the intracranial pressure, pseudotumor cerebri. So in this condition, you have to either stop, okay, you will have to stop the treatment with growth hormone, and once the effects come down, you can maybe start with the growth hormone with lower dose. Okay, so pseudotumor cerebri is another side effect of growth hormone. So slipped capital femoral epiphysis kyphosis can also occur. That is because once the growth hormone is started, so there is a rapid growth happening. So as a result, there will be slipped capital femoral epiphysis and kyphosis. Okay, so there are some studies saying growth hormone, as it promotes growth, can cause cancer. Okay, so but there is no much studies uh, proving it, and since growth hormone was started to be used as therapy at 1985, you cannot I mean, you still do not know the effects, long-term effects of growth hormone. But there was one study in France which said there is mortality due to bone malignancies have been seen, but there are other studies conducted in Netherlands, Sweden, which haven't detected such complications. So that is why now at present no guidelines have changed with growth hormone. All the FDA approved indications are still continued. So it might change in the future once if they get more details on the uh, cancer causing ability of growth. That is still not sure of. Another treatment where we use is in short stature is recombinant human insulin-like growth factor 1. So the indication being when there is insulin-like growth factor 1 deficiency. Okay, so deficiency which leads to growth hormone insensitivity. Okay, so conditions like Laren syndrome or deficiency of insulin like growth factor 1. At that time recombinant human insulin like growth factor 1 is given. So what are the side effects of recombinant human insulin growth factor 1? So these children might have hypoglycemia, increased intracranial pressure, and there could be adenotonsillar hypertrophy. So all these should be kept in mind when we are treating a child with short stature with recombinant human insulin growth factor 1 or also the growth hormone. So all these should be kept in mind. Side effects should always be kept in mind whenever we treat a child with any of the drugs. Next. So coming to summary of short stature. So what are the red flag signs of short stature? That's very important. So what are the red flag signs? So if there is a height uh, more than 2 to 2.5 standard deviation below the mean age, you have to always evaluate. Okay, if there is subnormal growth velocity, what is subnormal growth velocity? If the growth velocity is less than 25th percentile in the growth velocity chart. If there is abnormal body proportions, if there is derangement in the upper limb upper body lower body ratio, then you have to evaluate. If there is abnormal height to weight ratio, what does that mean? If a child who is obese with short stature, which is very odd, as what as I've said, obesity is a marker for accelerated growth. So generally, a child who is obese will be tall. So if a child is obese and with short stature, always rule out endocrine and genetic causes. If there is dysmorphic feature, so we have discussed now in the genetic causes. So there is Turner syndrome, there is Noonan syndrome, there is Silver syndrome, there is Testicular syndrome. So all these have dysmorphic features. So when a child with dysmorphic feature and short stature comes, again you need to evaluate. So dysmorphic features, even if the child, yeah, if there is a very evident dysmorphic feature and there is no short stature, also is a sign to evaluate the child. So goiter for hypothyroidism should be ruled. Presence of abnormal CNS system and ophthalmologic evaluation. So how, why, what do you think? So if there is any tumor, so many tumors can present with short stature, right? As I've said, craniopharyngioma can be, there could be pituitary tumors. There's so many tumors can present with short stature, and they might present with abnormal CNS symptoms. Okay, so these are the red flag signs of short stature. So I hope you have understood short stature well. So if you do not, you didn't understand, or if you need, if I've missed something, so please let me know in the comment section. I will try to get back to you and the next classes. Okay, so now we'll come to the MCQ. So I need to know if you all know. Hmm, So I want to know how much have you learned. So which of the following does not promote growth? Promote growth. So this is I've discussed twice, even yesterday and today. So growth hormone will promotes growth. How does it promote growth? By stimulating insulin-like growth factor 1, right? So that is how insulin-like growth factor acts on the bone. So growth hormone promotes growth. How does thyroxine promote? Thyroxine also promotes growth. So this acts on the bone as well as it has a permissive growth hormone effect. What does glucocorticoid do? It inhibits. So the answer is glucocorticoids. What does estrogen do? It promotes. So this helps in the maturation of the bone, right? So I think this is a very simple question. I've discussed 2-3 times. I think by now it should have entered your head that glucocorticoid inhibits growth. Okay. So what is the first sign of puberty in males? If you know the answer, let me know. Anyone knows the answer? Okay. So the answer is testicular enlargement. So always to know if the child has attained, if the male child has attained puberty, the first sign of puberty is the testicular enlargement. Which of the following is not associated with disproportionate upper limb to lower limb ratio? So I've just said disproportionate. So it could be increased upper limb lower limb ratio, or it could be decreased upper limb lower limb ratio. Okay, so we'll go to the first question, first answer. So achondroplasia has disproportionate upper limb lower limb ratio. Over here the upper limb lower limb ratio is increased. As you know, the trunk is longer than the limbs. Okay, so what happens in radiation induced spinal injury, spinal damage? So when there is radiation induced spinal damage, the trunk is shrunken. Okay, so over here there is a decrease in the upper to lower body ratio. So again it is disproportionate. What happens in osteogenesis imperfecta? So I've said just recently, I mean in the last slides, osteogenesis imperfecta causes proportionate short stature. The answer is osteogenesis imperfecta. Again, Turner syndrome causes disproportionate short stature. Over here, the trunk is longer than the lower limb. So here the upper limb lower limb ratio is upper body lower body ratio is increased. Okay, next. I would want to know who else is answering. Okay, okay. What is the upper limb? Whoever is there, I'm happy. Please answer. It would be helpful for you all also. Okay. What is the surrogate marker for growth hormone? Okay. So, what is the surrogate marker for growth hormone? As I said, growth hormone is secreted in pulses, brief pulses, and they reach a peak at sleep. Okay. So that is why you cannot take random growth hormone levels. It might be false. So what is a surrogate marker? What is a stable, what remains stable in the blood, and which will reflect the level of growth hormone? So that is insulin-like growth factor 1. Okay. So as I've said, growth hormone stimulates insulin-like insulin-like growth factor 1, and it forms a ternary complex. It forms a ternary complex with insulin-like growth factor 1, insulin-like growth factor binding protein 3, and acid labile substance. Okay, yeah. So all these are very important. Okay, all of the following about familial short stature are true except so the shape of the growth curve is normal, right? Okay. The final height is below the height compared to the peer. So your parents are short, even your height ends up being short. So you are shorter compared to the peers. Bone age is remarkably reduced. No. Bone age and the chronological age is equal. The answer is bone age is markedly reduced. That is because um, there is no delay. They follow a regular growth as how their parents have uh, as their parents, and they should reach at least the range at which their parents height come. Okay, in what happens in constitutional delay, that there the bone age is delayed. So there the bone age as well as the puberty is also delayed. Okay, now and this is true. The answer is to identify this child. So so this is Seckel syndrome. So as I've said, there is microcephaly, there is a prominent nose, okay, and the child is very tiny. You should always think of Seckel syndrome, okay. Clinodactyly is a feature of which syndrome here? Clinodactyly is a feature of which syndrome? Okay, so clinodactyly is a feature of Russell syndrome. So now, if anyone knows, hmm, can you tell me what is the feature of Russell syndrome? So there is severe IUGR and there is growth failure even postnatally, right? So there is clinodactyly. They have a triangle face, right? Then there is hemi-hypotrophy. Yeah, I think you should know this. Sickle cell, what I said was they have microcephaly. And what is it called? Huh? Yeah, tell me. Okay. Microcephaly, they have a prominent nose, they have a hypoplastic face. Okay. Okay, the answer is Russell Silver. So what happens in Prader-Willi? They have morbid obesity because of hyperphagia. Okay, and there is developmental delay. Yeah, and what is the genetics? So either it could be because of deletion of chromosome 15, okay, or is it or because of chromosome the Prader-Willi syndrome segment, deletion of the Prader-Willi syndrome segment, or in chromosome 15, that which is paternally inherited, or it could be the genetics could be because of maternal uniparental disomy. So Noonan is also known as pseudo Turner because they have features similar to similar to Turner syndrome. That's why they are called pseudo Turner. What is the cardiac lesion in Noonan syndrome? It is a right-sided heart disease. So what does it have? Pulmonic stenosis. Okay, they have a hypertrophic cardiomyopathy. Okay, what is the cardiac lesion in Turner syndrome? Coarctation of aorta. Okay, good. So this is done for today. Yeah. So we have discussed yesterday and today we've discussed about short stature. So most of the topics are completed in short stature. So if there is anything which you need to know, please let me know. I can update all with it. Okay, I will keep revision classes maybe once in a week with the topics what I've completed. But it would be very good if you all discuss in the live chat. Okay, so that I can improvise. So any feedback, let me know. Okay, yeah, yeah. And remember, this is my code Shilpa 10, and use my code to subscribe to the subscription. And good luck.